Hey, I think we're live now. That was sort of painful. Anyway, here we go. Here we go. I have 12 cases. Let's get started. First case. Patient was admitted to the ER with confusion. CT scan was done to look for a source. What's going on? Take a look at the kidneys. Look at the cortical medullary interface. The cortex is not enhancing. There's some enhancement of the medullary space. You're not seeing any excretion of contrast. You see venous and arterial enhancement. But what are you dealing with? Well, this appearance is that of shock kidneys. Poor perfusion. Sometimes with shock kidneys, you don't see the cortex and medulla enhance. Sometimes you don't see the cortex and you see some medullary enhancement. That is one of those cases. Okay, now we go. Another one, rule out dissection. When you look fast, it looks like something's wrong with the aorta. Then you realize that's the common iliac, and those are the veins. And this is something that's sitting right at the aortic bifurcation. Here it is very nicely on the volume rendered views. Aorta, common iliacs, there's the mass. You have an enhancing lesion sitting just beneath the aortic bifurcation. Here it is on cinematic, very nicely shown. What are we dealing with? We're dealing with a pheochromocytoma. Classic pheochromocytoma at the level of the organ of Zuckerkandl, where the bifurcation is. Another case, hematuria. There's a mass posterior aspect right kidney. It's higher density. With contrast, you can see it's a solid mass, but there are also other lesions present in the right and left kidney. You could say renal cell carcinoma, but then you could not explain these other lesions. What gives you multiple renal lesions and maybe a dominant mass? There's nothing in the liver, nothing in the spleen, no periodic adenopathy present, so it's really primary kidney. Well, the mass itself, although you always think about renal cell, could be lymphoma, and the multiple small solid lesions really push you to the diagnosis of renal lymphoma. A really good case. Fever, 30-ish-year-old female. This is a teaching point. There's a lesion here, and yes, I know it looks like it's a solid mass, can easily be a renal cell carcinoma, and of course fever can be one of the presentations of tumor. It's always a little bit tricky. This you can see a little bit better when I do the cinematics. You can see some of the haziness and redness around it, the edema. This was an abscess. Renal abscesses, when they're solid looking, like this case, can be easily confused with tumor. So a really nice example. Right lower quadrant pain. You see a lot of fat in the right lower quadrant, and then you see thickened ileum. Look at the coronals, a long segment of thickened ileum. There's some soft tissue thickening here, fibrofatty proliferation. This is a classic example of Crohn's disease with long segment narrowing. This area here was more mass-like, was concerning. You can see it again here and here. This ended up being resected. There's the fibrofatty proliferation, the prominent vasa recta. And this was Crohn's disease, but the area I was showing you was mass-like and had a high-grade dysplasia. Patients with Crohn's disease have an increased incidence of cancer. It's often hard to see on the CT scan. It's even hard for the surgeon who's palpating, and the diagnosis is often made on pathology. But if you see an area that looks different, at least warn the surgeon about that possibility. They would get intraoperative biopsies, because if not, they're going to have to go back a second time to resect local lymph nodes. GI bleed, what do you see here? Look at the patient's splenic flexure and descending colon is thickened, but look at it on the coronal. Look at the transverse colon. Look at the cecum. Look at the sigmoid colon. You're dealing with a pancolitis with really impressive ulcerations of the colon. Look at it with cinematic, really impressive pancolitis. You could think about pseudomembranous colitis. You could think about other infectious colitis. You also have to consider ulcerative colitis, and this was ulcerative colitis with large ulcerations and crypt abscesses. A really nice case. New onset diabetes, that would make you think of pancreatic cancer. There's something abnormal in the pancreas. It's low density and there's textural change, but there's no dilated duct. I would worry about a mass here, but this is one of the great cases where the patient with no dilated duct, you say, what's going on? Well, this patient had autoimmune pancreatitis. Autoimmune pancreatitis can easily be confused with pancreatic cancer. Classic appearance autoimmune is a cigar-shaped configuration. The edema around the gland, there's that halo. That's not the look of pancreatic cancer. And again, I've seen patients resected what ended up being autoimmune pancreatitis, so you need to be careful. Just a really nice example of a patient with autoimmune pancreatitis, but no pancreatic cancer. What about this pancreatic mass? Enhancing lesion, head of pancreas, coarse calcifications. We can see calcifications in many things, SPEN tumors. We can see calcifications in mucinous cystic neoplasms. We can see calcifications, particularly centrally, in serous cystadenomas, but this lesion's also enhancing. Although you could think about a serous tumor, when I see an enhancing lesion and I see coarse calcifications, I'm always thinking about a neuroendocrine tumor, which this indeed was. What about this patient with back pain? Cystic lesion, junction of body and tail of pancreas, well-defined, sharply marginated, no enhancement, no real septations. 40-ish-year-old female, that location is great for MCN, but you could have thought about a oligocystic serous cystadenoma. You could have considered a pseudocyst. So there's a number of things you could have considered. This was resected. This was an MCN. They did get in the US before, so again, not everyone's going to surgery, but that location and that wall is typically, you're going to surely have at a minimum an EUS. Incidental finding, tail of pancreas. This could be a splenule, but in fact it's denser than the spleen. It also has a punctate calcification. So you could think of accessory spleen, but they look identical to spleen typically. This was resected, and this was a neuroendocrine tumor. One of the challenges at times is a neuroendocrine tumor, tail of pancreas. Serous cystadenomas, at times when they're small, can be vascular. You can think about that. But usually the challenge is peanut, small peanut, versus an accessory spleen. Accessory spleens typically are separate from the spleen, but not always. Separated from the pancreas, but also it's rare for accessory spleens to calcify. Back pain, cystic lesion, body of pancreas, well-defined water density. Think about the MCN I showed you before. Think about oligocystic serous cystadenoma. Think about a pseudocyst. This was an MCN. Again, location, but MCNs are typically no dilated pancreatic duct. That's very helpful. IPMNs would have a duct. No dilated pancreatic duct, typically may have septations, may not. Typically not very vascular. Abdominal pain and weight loss. Mass head of pancreas, but it looks like it's more extensive and there's a lot of nodes present. Also, you don't see a dilated common duct or pancreatic duct. What can simulate a pancreatic mass be infiltrating without duct dilatation? This is not the look of autoimmune pancreatitis. I know someone said that in the back of the room. Of course, they were thinking about the cases I showed a few moments ago. This ended up being lymphoma. And B-cell lymphoma can sometimes present and simulate a pancreatic mass, particularly by the head of the pancreas. But a helpful thing is there's no dilated common duct or pancreatic duct. And that's the dozen cases. That's the quiz for today. I hope you liked the quiz. I hope it was helpful. And I hope you have a great day.